of Social Sciences and Professions. And I was reflecting on, when I looked at the programme in preparation for today, I just reflected on the history of this conference. So around 5 years ago, Jolanda came to me with the idea of having a conference in our health and social care area for two reasons. One was to showcase the fantastic work that our lecturers and teaching staff do outside of the classroom. But the second reason was to ensure that our students felt more confident in engaging in research. And our level 6 students who are in the audience, I know that this time of year is a time where you're starting to engage in your dissertations. And one of the things that we felt was really important was that our students had that exposure to a broad range of research methods. And what started off as a fairly small, modest conference 5 years ago has developed and grown into something that's really, really outstanding. And one of our proudest moments was the co-production of research projects with students co-presenting, and we've got some of that today. So I think today really for me just reinforces the importance of us have our commitment to a research informed teaching environment that stimulates your curiosity and creates that richer learning environment for you. I think it's also a chance for your fabulous tutors to showcase their excellence. They work tirelessly to provide you with an outstanding learning experience all the time. But today, I think it's really important for them to continue to do this in a way that shows the full range of the skills that they have and how they bring their research into the classroom to give you just the most excellent exposure to impactful current research. So not only are you going to be hearing from a range of colleagues from across the school, but there's also colleagues from more broader than that. We've got colleagues from other parts of the university, and we also have our PhD students presenting today, which is fantastic, and we're really really proud to see that happen. Looking at the programme, you've got a real treat in store for today. It's just such a broad range of issues that cover health, well-being and society, and never before have these issues been so much at the forefront of our minds and broader society minds. So I'm hoping that you have a really enjoyable day and that you get a lot from the presentations today. I'm going to hand you over to Jolanda, who is going to tell you a little bit more about the detail of the conference, but I'm really delighted to be here and I look forward to hearing the presentations too.
Okay, thank you very much, Kelly, and good morning, everybody. I'd like to welcome everyone to our 5th Interdisciplinary Health and Wellbeing Research Conference, which is organized by the Centre for Primary Health and Social Care at the School of Social Sciences and Professions. For those who don't know me, my name is Jolanda Iraso. I'm Professor of Health Studies and Director of the Centre for Primary Health. First of all, I would like to thank especially our Dean of the School of Social Sciences and Professions, Kelly Cooper, for her sustained commitment and support to our research development across her years in the management of our school, first as social professions and now as social sciences and professions. In addition, Kelly, as you notice, she has been a key supporter of this conference since its first running in 2018, and I'm very pleased she's here with us in our 5th meeting. So Kelly talked to you about some of the purpose of this conference, and I would like also to this set of goals or missions of the conference is to share knowledge, showcasing new and in progress research being conducted by our staff colleagues and students at all degree levels. Another mission has been to connect researchers, promoting a space for people to know what others are working on, and in this way to act as a catalyst for research collaborations in the future. Hence our interdisciplinary approach to engage with other methodologies and ways of thinking about challenging and complex health and well-being issues. And I'm very grateful to our presenters joining us today from the different areas of the school, such as health, community development, criminology and social work, and presentation from our student research programs, including PhDs and the professional doctorate in health psychology. And I have to say that it is a very varied program indeed, and we expected it to be truly interdisciplinary lenses to discuss issues of health and well-being, which we hope the audience, in particular our large audience of undergraduate students, will discuss with the speakers in our question and answer time slots. I'm mindful that we don't have a tight program this morning, so I will be very brief in considering the content of the sessions. So this morning we'll have 2 sessions, and there will be 3 sessions in the afternoon. Each session will be followed by 10 minutes for questions and answers, and then a comfort break to grab a coffee and to stretch. For the time allocated for the discussion, I'll encourage the audience to use the chat box as we go along. Please do ask your questions there, type your questions there, so we can go back to those questions as we monitor the chat at the time for discussions. Or alternatively, you can raise your hand if you would like to use your mic during the questions and answer time. Please note that we are recording the sessions, and the recordings will be uploaded to our YouTube channel, which you can access via the Centre for Primary Health and Social Care webpage. And for the speakers, it's just a reminder that we have 15-minute time allocated, and we will be checking on this to keep the program running on time. So we'll be letting you know when you have around a minute or so to run. We'll do this probably using the microphone, so apologize in advance for any sort of interruption. And so without further ado, I'll invite our chair for this morning's sessions, Ian Price, who's head of subject for health and early childhood, and will be introducing our first session. I really hope you enjoy the conference, and Ian, it's over to you now. Ian? You had your mic off, presumably.
Yes. Good morning, everybody. And can I also extend my welcome to everybody to this conference, and thanks again to Yolanda for putting the program together. I think without further ado, I will move on to the first speaker within our category this morning, which is looking at in session 1 vulnerable groups in London communities. And the first speaker is Lakis Zervoulis, senior lecturer in social psychology, who will be talking to us about understanding diverse LGBTQ plus communities in times of coronavirus and mixed methods. Lakis, just to let you know, we've got 15 minutes, and I'll let you know as discreetly as possible when you get to within about 2 minutes of the end, so that you know your time's coming to an end. Otherwise, over to you. Thank you very much. You could also ask people perhaps to make sure initially that their cameras are off and their microphones are muted, to avoid the risk of any disruption to our signals. So thank you very much. Lakis, over to you.
Thank you, Ian, and thank you, Yolanda, as well, for inviting me. This is my second year in this conference. I started kind of presenting what we were planning to do last year, and here we have the findings. Can I just confirm you can hear me, you can see me, you can see the slides, everything is okay, yes?
Yes, perfect.
Okay, great. Okay, so this is a project we had just got funding last February, around this time, and we were in the planning stages. So here we have some kind of results. It's a project to understand LGBTQI plus communities, so studying for lesbian, gay, bisexual, transgender, queer, intersex, plus allies. You know, not necessarily allies in this case, people who kind of fall in this category in times of COVID. And this was a mixed method study. So I'm a social psychologist, as Ian already introduced me. And my working team, it was made up by Professor Louise Ryan, who is the leader, and she's a sociologist, Donna Jones from social work, and then 2 London Med students, Chinar, Anna Chinar, for example, is from media studies. So you can see how also multidisciplinary is this team. And here I have kind of, this is a study that took place at Lambeth Council in London with few partners, including Blackout, Black Thrive, Lambeth Links, Opening Doors, try to capture as many people we could from the LGBTQI plus community with all sort of diverse characteristics like older people, for example, women, people of color, and so on. A bit of background, why LGBT plus people? And I may kind of, I may start using the term queer instead of saying LGBT plus identities. It makes it a bit faster as I present, but please forgive me if you don't necessarily identify or kind of recognize this term. By queer, I will be including all these groups for the purposes of this presentation. So a few findings. Why is this kind of a vulnerable identity, let's say? Homophobia, you may have heard of it. It was defined, many years ago as the dislike or hatred towards homosexuals. And nowadays, it's kind of, we don't talk just about homophobia. We're talking about transphobia and related phobias in terms of diverse sexuality. Another keyword, heterosexism, heteronormativity. These are kind of the heterosexist positions, things that, when we grow up in a relatively heteronormative society when people do assume that everyone is heterosexual. And from the moment, you kind of even become teenager, if you are a boy, your parents, relatives may be asking you, do you have a girlfriend? Is it somebody you like on the opposite sex, and so on. And linking that to patriarchy, the privileged position, if you like, of man, not just in westernized societies, but definitely in westernized societies, then you can understand how diverse sexuality may be affected. Homophobia and kind of negative feelings towards queer communities is also based on moral condemnation. It has its roots in many ancient cultures across the world, and many religions, especially monotheistic ones, and their moral positions. Then even scientifically, there was homosexuality was in something like a pathological condition, and it was eventually removed as an official category of kind of a disease from the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders, known as DSM, only in 1973. So even if we're talking within the West, 50 years ago, you would have been considered, if you were a queer person, considered to be suffering from some kind of mental health condition and be referred to psychiatrist to reverse this condition. And then kind of how homophobia, transphobia, and so on get expressed in real life in terms of behavior. There is a lot of evidence that queer people are subjected to violence, whether it's verbal or physical. And this slide kind of, I have a couple of lectures, full lectures as part of social psychology talking about stigmatized identities and sexualities. This is kind of a very rough summary stating why queer communities are kind of stigmatized. Effects of this stigma. Various studies from 70s, 80s to 2000 to this century. Stigma linked with emotional distress in the case of queer people, confusion and self-contempt, according to Sullivan and Snyder, already from the 80s, linked to school failure for younger queer people, poor psychological well-being, deliberate self-harm, likelihood of poor self-image that can lead to depression, anxiety, promiscuity, and addictive disorders, depression, low levels of self-acceptance and self-esteem, higher rates of suicide attempts, and even higher among people of color who belong to the queer communities. internalized homophobia or homonegativity. This is the phenomenon where lesbian and gay people are to a variable extent unhappy about their own sexual orientation on the basis of the attributes that are given to this sexual orientation by others. And this is also associated with depression, dysthymia, kind of bad mood, and a likelihood of being in therapy, lower self-esteem, and greater loneliness. And there was even a kind of finding within Lambeth Council, though, when they started investigating the effects of COVID in the general population within the council, that queer communities were affected even more because of COVID-related isolation. And that was only kind of a few months before we started our study. This project then got developed because Lambeth had kind of needs to investigate the community. We found an opportunity to access the council, if you like, with the biggest queer community in the UK. So we set out to satisfy some of the aims of Lambeth Council, but obviously doing a bit of sociological and social psychology research as part of the challenges posed by COVID and the associated restrictions. Now, we were also mindful to investigate as much as possible diversity within the queer communities, because usually kind of a lot of studies tend to recruit the middle class, usually white, man, Western European, and quite often ignoring communities, sub-communities within the queer community. So kind of we try to capture underrepresented populations. And as part of this study, we wanted to kind of co-design solutions that relate to mental health, physical health, but it was going before that. You will see me, I will kind of focus on the health aspects just because of the remits of this conference. How did we go about it? So we kind of designed a very comprehensive, quite long survey. We were hoping to even kind of not have it just online, but we ended up just administering it online or via the telephone when we realized some older people wouldn't be happy to kind of spend half an hour on 1 hour to just complete a survey. We were also planning to do postal surveys or even access venues, but because of COVID, you can imagine the challenges. And this kind of affected our recruitment of diverse communities. So if you are doing an online survey, you are more likely to recruit people who are digitally educated and so on. Of course, we were mindful about this, and I will explain how we tried to work around it to a great extent, or to some extent. And as part of the survey, we obviously collected demographics. We collected information about understanding of the services that Lambeth Council was providing and how happy people were. We collected information about the level of companionships and support networks that our participants had, and then all sorts of measurements around well-being and mental health. Now, we already anticipated that despite our efforts, for example, we used a lesbian dating application on the phones to recruit even more women, or we kind of, through our partners, we tried to recruit Black LGBT plus people, for example. But even though it improved characteristics of samples on the basis of what was happening so far, we knew that it's not going to necessarily convince many people to sit down and complete a survey. So we kind of improved our statistics. Out of 190 survey participants, we managed to, if you like, restrict the gay white male sample to only 56%, when usually it's kind of more than 65%. So that was a bit of an improvement. But as part of our planning, we anticipated that, how are we going to capture these diverse communities? And we focused in this occasion on LGBTQI plus people of color. So we developed this Photovoice research project as part of our main project to follow up from the survey, where we would be speaking to about 10 people. We actually managed to get 11 co-researchers who would be participating in 3 workshops and I will describe with this what this Photovoice is. And at the end, kind of the final workshop with 9 of them included a focus group. So as you can see, we were planning, we didn't know if it's going to happen online or offline. It ended up luckily for us happening offline, because this obviously creates a bit of a better sense and allows people to feel safer. Photovoice, just a few words, is an art-based method to create safe spaces for marginalized voices. So you can see why talking about LGBT people and people of color was very important. And it is, you can read the whole paragraph here, because of the time, I'm not going to go into details, but it's a pedagogical tool in order to capture and reflect some of the lived experience of the participants, who then become co-researchers. So they get trained to take some photographs. That is up to them what they want to take, and speak around those photographs and provide kind of valuable experiences where people can go and read about. Going to the findings that can be linked to COVID-19 and its consequences. Higher proportion of LGBT plus people are not in a relationship nor have children. This may still distinguish them compared to the majority of heterosexual people. So imagine if you're an older person without an extended family, how much you experience isolation. Black, Asian, and other minoritized queer people face even more marginalization, and not just like every other gay person, gay plus person, but also within the broad queer community. Satisfaction levels for the health-related support of people with disabilities or long-term health conditions was relatively low. COVID has affected housing, employment, income, as well as general health of queer people, but the less wealthy, as you can imagine, are affected more. Mainly anxiety, but also general mental illness are on the increase as a result of COVID-19 and its consequences. Technology can help overcome loneliness and facilitate access to services. However, people wanted to speak to somebody on their phone on the other line to have some kind of personal contact. Verbal abuse, despite the kind of lockdown on the streets, remained high, and this was more directed towards females and non-binary people. And queer people, physical spaces have been missed a lot. But even when kind of there were these kind of spaces, these were mostly catered for white people and not the minoritized people. So this is something that could have been taken forward following these findings. Just kind of a snapshot of some of the important findings, health changes due to COVID that I have already read to. If you see already kind of the third biggest column here.
Lakis, you have 2 minutes left.
2 minutes left. I'll try to be as fast as possible. So you can see that people reported being less healthy just because of COVID. You can see that those who actually were kind of in the lower income categories, they will be affected much more severely in terms of of income. You can see that again, those who were in smaller socioeconomic status, if you like, economic status, they reported a lot of kind of poorer health. So you can see the relationship between health outcomes and finances. Then this relates to abuse, what I was describing, that that females and non-binary people were more kind of the victims of verbal abuse on the streets. And then some kind of correlations in relation to contact and well-being. So people who reported to have social support, they felt less lonely. That's why you get the minus. This is a very high correlation coefficient. They were more satisfied with life. They experienced less anxiety, and also satisfaction with life correlated negatively with loneliness. Satisfaction with life correlated negatively with anxiety. So these are kind of expected figures, but we had a decent sample to be able for us to investigate. And then as part of Photovoice, this is just an example. This is a type of a picture that co-researchers would produce, and just read this quote. The pictures of me in the dark room with my hands tied depict isolation, my voice not being heard when it comes to mental health issues. It depicts how depressed I was during the lockdown. I was depressed already, but it became worse with the pandemic because I had to, at some point, leave the house. I was in London to Cardiff due to the hateful remarks about my sexuality from family. So you can see kind of strong quotes. Recommendations on the basis of this: maintenance and promotion of physical LGBT spaces that are sober. They don't necessarily provide just to the white majority and the male majority. Safe spaces also for older people. There was a very good comment about older people not having access to other generations that heterosexual people would have, probably because of grandchildren and children. And older people just end up being alone in their life until very late and not necessarily communicating with younger peoples. Needs in terms of residential care, need for communication in terms of telephone, and also kind of visibility, where are those kind of services, and of course kind of provide diversity of recognize diversity, involve people of diversity within decision making and so on. And I rushed through the whole thing, but I hope I'm kind of just on time. Any questions you may have, please feel free to contact me. My details are there. Telephone is a little bit less popular nowadays, but you have my email, and you can read a lot more about the project, including having a look at the executive summary and the full report at londonmed.ac UK LAMQ, which is Lambeth Queer. And also, if you're close to Brixton until the end of the month, as part of the LGBT plus History Month, we have the exhibition of Photovoice, where you can see all the photographs together with the quotes. That's Brixton Library. And that's all from me. Thank you very much for the space, for listening to me. And I guess I will be here to take some questions at the end of this session.
Thank you very much, Lakis. It's very interesting. I suppose really that just re-emphasises the importance of our concern for potentially marginalised and vulnerable groups in the pandemic. So thank you very much for that. As Lakis has suggested, there will be time for questions at the end of the second presentation under this category. So if I can turn now to the second presenter, Alison Backhouse, who's a lecturer in health and social care. I suspect many of you know Alison, who will be talking about a collaborative scoping project to find out if dementia care mapping is more effective when using forum theatre in its feedback processes. So thank you very much, and over to Alison. Just to let you know, Alison, that I'll let you know when you've got about a couple of minutes left within the 15 minutes. Yolanda, is Alison here? I did see her. I did see her join.
Yeah, I made.
Yeah, I'm here.
Oh,
Hi.
jolly good.
Hi.
Over to you. I was just saying, I don't know if you heard. I'll let you know when you've got a couple of minutes left.
No, I had a bit of a internet connection problem, so I had to rush into university. I was going to come here, and then I thought I'd solved it. Anyway, hello everybody. I'm going to tell you a bit about this collaborative project. I'll give you an overview to begin with. I was interested in person-centered care. I'll just go one slide back. How come? Oh, is somebody else moving my slides? Can I go back to the first slide? Can I do them? Okay. Yeah. So I was interested in person-centered care. How was person-centered care being taught to healthcare assistants in residential care homes and nursing homes and in care agencies? And I came across an article that said the main tool that people were using was a thing called dementia care mapping. And so I was interested in that. Then I read a bit about that. I looked at this article here, and from the Institute for Health Research, and talking about how the implementation of DCM, dementia care mapping, was the most sort of widely used tool, but had very variable outcomes for various reasons. And so that started me thinking, and I remembered a wonderful workshop that I'd done with Greg from Social Work and Ryan Arthur called Forum Theatre, about theatre of the oppressed. And so I thought, oh, perhaps we could include some of those techniques, the form theatre techniques, into the feedback cycle of this dementia care mapping tool that was that had been created by University of Bradford. And so that's what sort of started us off. And then Ryan talked about doing ethnographic research, and we got a nursing home or residential care home in Islington involved. And so we're just about on the cusp of starting all of this now. And we've done all of the kind of groundwork, but that's sort of an overview. But Mida is here. I think Mida Ramchand's here to tell you a little bit about dementia care mapping. Then Ryan's going to talk a bit about ethnographic research, and then I'll sort of finish off talking about a little bit about forum and forum theatre and about Bridgeside Lodge. So is Mida here? Sorry, I'm so late. I don't know if Mida is. Are you here, Mida?
Yes, I am here.
Yeah. Okay. So
Hello,
are you
hi,
okay? Shall I hand over to you?
Can someone move my slides, because I don't think I can access from my place.
Okay, so they're the other set of slides.
Yeah.
Okay, yeah.
I'll
Okay,
upload those. I'll
Okay.
upload those then. Give me
Let
just
me
a
see
So
if I-
Mida,
second.
do you want to introduce yourself and just say,
Yeah.
you know, a bit about your...
Yeah. Oh, here you go. That's it. Thank you. So good morning, everyone. My name is Mida, and I am presenting the dementia care mapping process. So the process of dementia includes 5 phases: preparation and briefing, observation, analysis, report writing and feedback, and action planning. So firstly, preparation and briefing. The mapper prepared the people on the unit, staff team, people living with dementia, and their family members on the dementia process by providing briefing sessions. The briefing sessions involves providing information about DCM, to identify who will conduct the map, provides an opportunity to ask questions and raise any concerns, and it also provides an opportunity for mappers to familiarize with the participants, staff, and family members by providing information leaflets and posters. The briefing session should take place several weeks before the mapping. So the next phase is observation. So before conducting any observation, consent needs to be obtained. Observation should take place in a communal area. The observer records the care experience of up to 8 people living with dementia for up to 6 consecutive hours. The duration of the observation will depend on the reason for the map, and this can be shorter or longer than 6 hours. Continue with observation. After every 5 minutes period, the observer should record a behavior category code, a mood and engagement value, and also the quality of interactions with staff for each person the mapper are observing through personal enhancers and personal distractions as and when they occur. The BCC and ME value are recorded in a data sheet, whereas the PE and PD context are recorded in an additional field notes. So this slide shows an example of raw data sheet that the observer should use to undertake the observation. There are codes which are used from the mapper as shown in the table. There is a lookup table for all the coding. As shown in the table, the mapper has used the BCC and ME value for observation. The next phase is analysis. The information from the raw datasheet is fed into a software program to complete calculation as well as presenting an in-depth data analysis. The data analysis should provide the following: how individual and group levels of well-being and ill-being vary across the observation times, which participants have relatively high or low well-being experience, how people living with dementia spend their time, and also staff interaction that promotes or undermine person-centered care and well-being. All the above data analysis will be presented in a graphical format from the program. The next phase is report writing and feedback. Based from the data analysis outcome, the mapper should provide a written and verbal feedback to the staff teams. The mapper should work jointly with staff team to investigate further into the detail of the written report and using open-ended questions to facilitate discussion and reflection. And finally, the final phase is action planning. Following verbal feedback of the written report, the staff team shall develop action plan for individuals or groups of individuals who have been observed. In some instances, this may be supported and assisted by the mapper. The mapper shall undertake the following actions: record what was agreed with the staff, plan a date of when the action plan will be reviewed and by whom, and also set a date for the next DCM evaluations. That is all from me. Thank you very much for listening, and I'm going to be here for questions.
Thanks, Mida. Am I sharing? Yeah. And so I'm going to go on to Ryan now, but just to say that Mida and Greg from social work. Mida is a student, an ex-student who was on the public health masters and working with dementia. And she and Greg went on training to learn how to do dementia care mapping at the University of Bradford, kindly paid for by London Met. And our idea is to add on to that end section, that action planning section, the forum theatre techniques, which I'll talk to you after Ryan's talked to you about ethnography.
Hi guys, good to be back. My name is Ryan Arthur. I used to be academic mentor here last year. I now coordinate learning development at Birkbeck. Can everybody hear me okay and see my screen okay as well?
Yes.
Excellent, great. That's great.
Yes.
So let me jump. So thank you, Alison. So it's good to see everyone. I'll be talking very briefly about ethnography and its application in our project. As many of you guys will know, it's difficult to discuss this topic because ethnography is not a straightforward approach. It's difficult to find clear descriptions of ethnographic principles. I would argue that this is due to its roots in anthropology and its later usage within other disciplines and other situations, all of which brought about conflicting intentions and conflicting foundations. However, we still need to muster a definition. So our aim for using an ethnographic approach is to see and describe the processes, the meaning making, the interaction at the Bridgeside Lodge residential care home through the medium of performance. We intend to gain an insight and understanding of a select group of care staff by immersing ourselves within the cultural life of the Bridgeside Lodge. For a number of reasons, we were led down this ethnographic path. First, the ethnographic approach is the epitome of qualitative research. From our very first discussions, Mida, Alison, Greg, and I were adamant that we wanted to adopt a qualitative approach. We wanted to explain or interpret the rich complexities of the cultural life of Bridgeside Lodge. Second, ethnographic approaches are very common in examining care settings and workplace learning. Third, it would be contradictory to select a methodology that opposes the ethos of the forum theatre. The forum theatre is not dogmatic, Likewise, ethnography is a highly flexible approach in which types and locations and even the focus of our data collection are determined by developments in the field and our emerging understandings. Also, the forum theatre challenges hierarchies and it blurs the line between actors and spectators or spect actors. Likewise, ethnographic approaches seek to immerse the researcher within the real life activities of that particular culture, allowing an exploration of interactions and meaning making. Fourth, the location is very important. Very early on in our discussions, Alison was adamant that she wanted to gain access to a residential care home. She did not want to conduct this study from a distance. She wanted to be up close and personal. At the time, I didn't think this was feasible and I thought it would be too challenging to gain access. So I settled on conducting a theoretical project. But Alison managed to gain access amazingly. She negotiated great terms with the care home. And reading the ethnographic literature, this notion of location really stands out. It's vital for the ethnographer to be present because ethnography is always grounded in a specific location and what goes on inside that location. That location becomes what is referred to as the practice space. Settled on ethnography, we see two distinct approaches. There's the ethnographer who's looking for good translations and the ethnographer who's looking for good vibrations. The good translations ethnographer is a committed constructivist. He or she seeks to translate the symbols of the cultural life at Bridgeside Lodge.
Ryan,
whereas
you've got 2 minutes left.
2 minutes left.
Yeah.
Okay. So bridging all of this together, let me move steadily on. We settled on a notion of performance ethnography. So that is bringing this notion of good translating the symbols that we experience in this care home, and also the good vibration aspect where we are immersing ourselves within this particular culture to gain a deeper understanding. So performance ethnography is a mean to bridge these two dichotomies together. Performance ethnography provides us with a way to translate the symbols at Bridgeside Lodge from a distance, but also to embed and immerse ourselves and find a way into the cultural life of Bridgeside Lodge. Both performance ethnography and the forum theatre come out of the critical pedagogy tradition as a means to create understanding through involvement and collaboration. If you'd like to wrap up, Angela, I will just take my screen off. Sorry, Alice. It's one of those words.
Tell me about it. Thank you, Ryan. That's fantastic. Can I just have my slide back just to show you Bridgeside Lodge, or do I have to stop now? Oh yeah, great. Just the last one. Just so yeah. So we've got to start, but with this is Bridgeside Lodge where we're working, and all of this is going to happen. And they're really keen for us to come in, and they've got an outstanding CQC report. So we're going to start working there this month, hopefully, adding on this dynamic fit part of using forum theatre as at the end of the sort of feedback loop after all of the sections that Mida talked about. Okay, yeah, that's us. Is that, can you, yeah. I'm worried that we're out of time, so yeah.
I think if you've got a couple of minutes. We're slightly ahead of schedule, so if there's something more that you need to say, but just literally a couple of minutes would be fine.
And so forum theatre, as Ryan was saying, is this way of making this quite technical training that Mida was talking about much more dynamic and sort of maybe making it something that people can commit to a bit more. And so the University of Bradford, who created this tool, and Tom Kitwood, who originally was the sort of father of the sort of person-centered care, they're quite happy for us to experiment with this idea and see if adding in these forum theatre techniques, which is basically people using the observations that Mida and Greg collect to set scenes, and then for the healthcare assistants to look at those scenes and then redirect them in ways, or even take the roles and redirect the roles and say, you should do it like this, and or you could do it like this, and redirect what they see in front of them as their day-to-day work. And it's a very empowering way of understanding and empathizing. And that's why we thought that with this very technical observation process, we could then add in this dynamic thing at the end to just give it that extra oomph, because at the moment there isn't that kind of commitment. And it is DCM, the thing that Mida was talking about, is the most widely used in this country to help people to understand person-centered care, which, you know, it needs to be effective, really, because we're expecting person-centered care to be in all of our residential and care homes and nursing homes. So yeah, so that's the project. And we're just, the next slide actually is we've got to go get ethics approval. Well, that will be difficult because I haven't sent the form yet, but I'm going to do that. Then we're going to observe at Bridgeside Lodge. So they've done all the preliminary observations there for their course, but now we're going to do the observations for the extra kind of added on forum theatre technique section. Then we're going to do unstructured interviews at the end, and very much sort of fitting in with that ethnographic way of working, and see if from that there was any interest in the forum theatre techniques, but not to lead that, just to find out what it is that people found good. Yeah, it is very exciting. Okay, that's it. That is it.
Okay, thank you very much, Mida, Alison, Ryan. We now open the floor to questions from the audience, virtual though you may be. You can either raise your hand, or if you'd rather type a question in the chat. So we have a few minutes for questions, and if you could initially also indicate who your question is aimed at, that would be really helpful as well. Faisal has got his hand up. So if you'd like to ask a question, off you go. Faisal, if you're trying to speak, you might be on mute.
You might need to make Faisal a presenter. Let me see if I can. There we are. Faisal, I've made you a presenter, so hopefully you should be able to use your mic now.
I think Faisal might be having perhaps a problem with the mic. Oh.
I believe so. He suggested that
he will be typing instead. There are some questions in the chat box, I think. Ian, you want to go through the chat box?
Yeah, I can't see any questions there. Unless
some questions. Do you want me to? I have one question. I start with.
I can't see any questions in the chat box.
Okay.
And it seems to be up to date, so I don't know what's happening to my end. But if you have a question, please go ahead.
Alison, thanks very much for this presentation. I think it's a very interesting project indeed. I had a question on this last slide where you're saying about the future. Are you planning to interview patients?
No, we won't be interviewing patients. We had a long discussion about this, but Ryan was quite clear that that wasn't probably the way that we should go. And it's, yeah, we're asking about the interest in the training. We're asking the healthcare assistants themselves how they like the training. We're not looking at the outcomes for the patients on this project. So yeah, because that brings in, and I think Ryan can, but that brings in a whole load of other issues if we're interviewing patients who have dementia. And at the moment, what we're doing is we don't have to get consent any further than how Mida outlined it. We don't have to get written consent from the patient, because this is part of their normal development, staff development. And so this is how dementia care mapping, the training approaches it. But you might want to say something, Ryan, about why we don't want to go down that road of talking to patients.
Just more so, it was just more feasible to interact with the care staff, because I know it opens up a whole black box of ethical issues if engaging with the patients with dementia, and I'm sure Yolanda, you probably know more than most so we thought we'd just keep it practical and feasible and just focus on something that is part of staff development anyway. It's part of the natural way the organization is run. So
absolutely. Yeah. Absolutely. Thank you, Ryan and Alison.
Faisal's questions appeared in the chat, so I'm assuming that this is for the second group, wanting to know how the approach would work across various residential care settings, for example, mental health or child, as obviously your initial focus was on dementia.
Well, it is called dementia care mapping, but Mida may be able to answer that a little bit more. Like, did they talk in the training? Because
I wondered whether this was more to do with forum theatre. But
sorry, I didn't hear the questions again.
The question was, I think, around forum theatre and how the approach would work across various residential care settings, so mental health or children's settings, in terms of perhaps evaluating a training for staff in those contexts.
I see. So adding in the forum to other training. I see. Okay. Yeah, I mean, forum's been, we haven't said much about forum, but Greg is the expert who's the other collaborator on forum theatre, and Ryan, but forum theatre can be used in just about every setting, really. And it's I had a little video that you could watch, but you can easily just go on to YouTube and find any videos about forum theatre. It's very empowering. It's yes, you can use it in any setting. And I think, am I right, Ryan, that Greg uses it with social work students?
Yeah, with social work students. Yeah, it's very adaptable within youth settings and stuff. So how we saw the dementia care mapping, we didn't see it as from the literature in terms of being effective. So we thought by including the forum theatre aspect, maybe this could make it much more effective. So yeah, so I can see it being used in a variety of contexts. I can see it definitely.
Sorry, we are a bit pressure with time, but Egoyibo, you have a question? You have your hands up.
Yeah, regarding the mapping, I was just looking at the data. I'm just wondering, what is the meaning of the BCC, LME, this example of the raw data sheet. So she did not describe what is the meaning of the BCC and ME.
Yeah, because of the time, but I did give a little
because it's like everything was just
so a behavior category code represent what each individual was mainly doing for that 5 minutes period. And
so the BBC is a behavioral what category?
Yeah, it's basically the mapper. It represent what each individual was mainly doing for that 5 minutes period. You know, the mapper record every 5 minutes of the observation at the end of every 5 minutes. So at the end of every 5 minutes, we have like a coding book. So we have a coding. So like basically as, I don't know if I can go back to, I can just show you quickly. So the BCC code, it's like there is a code from A to Z. So A can be articulations, that's mean interaction with other people, or it can be nodding as well. And there is like L mean leisure. And
L mean leisure.
L mean leisure, K means, F means food, when the person is eating food. So you see from A to Z, each code has a behavior.
Okay.
So, and then there is also a mood and engagement value. We have a list code as well. So the mood and engagement is between, so you have -1, which means a negative mood. There is +1, which means the person is on neutral, so it's not showing any negative or positive mood. And you can see on this there is +3. +3 means content considerably positive mood. So when we did our training, so we learned all of this coding. So this come with lots of experience. It need to be like very highly DCM mapper, need to do lots of mapping, and also every time we go for map, we have to carry our coding. So basically we have a manual with all the coding on it. Yeah, does that answer your question?
Yeah, I'm just worried about the niches of that. Yeah, thank you. Thank you.
There's a link in the chat there that you can find out.
Yeah.
Yeah, I've seen it. Yeah, thank you. The BBC.
Thank you. Any questions? Any other questions from anybody?
I think Faisal, I don't know, Ian, if you can read this in the chat. Faisal question was, just wanted to ask how you feel the approach will work across the various residential.
Ryan has answered that.
Care settings, yeah?
Yeah, Ryan answered that, yeah. We've done that one.
Okay.
Can I ask a question? Can I abuse my position as chair? All power corrupts. Can I just ask what made you think about using forum theatre in this context? Because has somebody done it before, or what led you to design it in this particular way?
Greg and Ryan put on a workshop about 2.5 years ago about forum theatre, and I hadn't really heard anything about it before, and it was just so inspiring as a tool that's empowering and just helps you to understand. So it was the best workshop, and unfortunately it was attended by I think 4 people, and it was just crazy because it was such a brilliant workshop. It had so much potential, but yeah, I don't know how Ryan knew about it before that, but yeah, that's how I first knew about it.
So has it been used before in this kind of context, do you think? Do you know?
And there's been a long history of using performance-related stuff within dementia care, within care settings as well. So in order to get the patients involved and get the care staff involved. So it's kind of unique how we're using it as a training mechanism within that setting. But it's been used generally.
That's what I was asking about, whether that's been done before.
So not specifically within the dementia care setting. So this is something, yeah, brand new and everything. But Greg has used it in other contexts as well. So he feels it will enhance the DCM.
Okay, great. So London Met breaking new ground.
Can I have a quick question, Ian? Again,
mindful go on then, Yolanda.
Of time.
I'll allow you.
I'm mindful of time, but this is for Lakis as well, for his presentation. I don't know, Lakis, are you there? Yeah.
Yes, I'm here.
Just a quick question. You mentioned that you have this Photovoice approach, and then you have interviews and focus groups, and then you have some data, the quantitative data from your survey. So in your findings, I'm interested in are you planning to sort of integrate the three methodologies, or only qualitative and the survey, which is the most sort of traditional or way of doing it? But what are your plans in synthesizing these three methods?
Yes, in terms of non-academic output, like for example, we had two events at Brixton Library. One was this Tuesday, when we were taking the findings and trying to do, for example, similar projects with Parapride, which is an organization for LGBT plus people who have a disability, then Black Thrive, mental health, and so on. So in terms of non-academic, we are thinking of combining these methods to do further studies. In terms of academic outputs, I'm not sure if Louise Ryan is today here. If she's here, she's going to tell me off. She's waiting for me to send here a first draft of a paper that is actually aiming to combine at least the survey, the quantitative data, with a lot of qualitative data that are part of the survey, because we had few open-ended questions, together with the focus groups that Louise conducted and the telephone interviews that she conducted on the back of both the survey and the Photovoice. Now, with Photovoice, it's a bit more complicated, because the people who take part, they're co-researchers. And it's kind of, because we don't want to interpret necessarily what they are telling us, they have ownership of the research. It will be very difficult to provide an academic output for that. But everything else, focus group, telephone interviews, qualitative online survey, it will be in one paper to start with.
That sounds fascinating. You can write, I assume, that paper with the people who took part in the Photovoice as well. I mean, so as a way of not divorcing them from the research process, isn't it? You could co-write with them. That would be a way around it, wouldn't it?
Yes, it's just I don't want to take ownership of that, because Donna Jones, our colleague from social work, is the one who is responsible for this.
Okay.
And it's, you know, it's something that I cannot, because I don't have this contact with the co-researchers myself.
Sure. Okay.
It will be something that my colleague will have to negotiate with them and see if it's beneficial to also the co-researchers and so on. Because sometimes, you know, we come from this academic perspective, what is beneficial for us, but it's not necessarily important for people who take part in this research, if you like. So it is something for Donna to negotiate with her team, if you like.
Okay, thank you very much.
Thank you very much, Yolanda, and thank you, Lakis, Mida, Ryan, and Alison, for their presentations. In the interest of sticking strictly to, or as strictly as I possibly can, to the timetable, I'm going to take a break now for 10 minutes or so. If we could be back ready to start at 11:15, which doesn't give you a huge amount of time, but please try and get back so that we're ready to start at 11:15. So thank you very much.